Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Bad Talks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra Season 3. Today's topic is very interesting topic: painful neuropathy in diabetes. Diabetes Essential is brought to you by your zero-calorie electrolyte drink Invasal Zero. Now, before moving forward, I would like to announce the last week quiz winners: Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Girish Desota from Mumbai, Dr. Bharat Praveen Mittakota from Surat, Dr. Ravi Bhatt from Sirsi, Dr. Atul Doshi from Mumbai, Dr. Anand Purande from Mumbai, Dr. Rinku Gupta ji from Mumbai, Dr. Sujit Kalsi from Noida, Dr. Rabindranath Katta from Tumkur, Dr. Ashwini Kumar from Kanpur, Dr. Sachin Lokhande from Akot, Dr. Subhash Jethwani from Mumbai, Dr. Hemant Adikane from Pauni, Dr. Rakesh Bhargav from Delhi, Dr. Ashutosh Das from Tamluk, Dr. Jitendra Kumar Shah from Bayat, Gujarat, Dr. Shashi Khare from Bhopal, Dr. Satish Kumar Jain from Bangalore, Dr. M.R. Chippa from Badmer, Rajasthan, Dr. Sanjeev Puri from Hoshiarpur, and Dr. Pradeep Patro from Chhatrapur. I would like to thank all the doctors to take part in our quiz. Now to enlighten and now to enlighten us regarding today's topic, I would like to welcome Dr. Sanjay Kalra, past president, South Asian Federation of Endocrine Society, chairperson, Education Working Group, International Society of Endocrinology. Over to you, sir.
Thank you, Ankur, and greetings to everyone. We have people logged in from across the country. Welcome to Dr. Devraj Dholaria from Surat in Gujarat, Dr. Anup Shukla, and Dr. Aditya from Chennai, Dr. Pradeep Rawal from Ujjain in Madhya Pradesh, and also Mr. Sharma from Lucknow. Let's talk today about painful neuropathy. And this is actually a very it's a very painful issue for the patients who have to live with this disease. Many times people assume that painful neuropathy cannot be cured, cannot be managed, but that's wrong actually. We can do lots and lots to help our patient. So I hope my slides are visible. I'll continue. Now, when we classify complications of diabetes, traditionally we classify as acute and chronic. In chronic, we have vascular and non-vascular, and in vascular, we have micro and macrovascular. Neuropathy is one of the microvascular complications because it is mediated by uh, by abnormalities or dysfunction in the microvasculature of the body. Often, like with all other complications, neuropathy also remains undiagnosed. The reason is that patients present only with severe symptoms. If we were able to catch them earlier, we would be able to reduce morbidity, also reduce progression of disease, and we would be able to resolve other risk factors, which might be related to glucose control, which might be related to control of comorbid conditions like lipids, blood pressure, weight, and which also might be related to reduction of behavioral risk factors like smoking. So, early diagnosis is important. It's also important to remember that peripheral neuropathy is associated not just with nervous or neural symptoms, it is also associated with mood disorders like anxiety, depression, with sleep disorders, and also with expenditure. If you have someone with neuropathy, the expenditure is going to go up, the outcomes are going to come down. If you have someone with painful neuropathy, expenditure will go up, outcomes will come down, and satisfaction with the healthcare system will come down markedly. So it's good to know about neuropathy and to ask our patients each time, do you have any positive symptoms like pain or burning, tingling in the feet, in the legs, in the arms, anywhere? Or do you have negative symptoms like numbness? So many times patient will come with pain, burning. They will use different words for that. Be aware of all the words regarding pain, synonyms of pain in your local language. It is also possible that the patient may present with something which is superficially different. Patient may say, "My feet feel hot," "My feet feel cold." This also can be a type of pain. These are positive symptoms. Negative symptoms are numbness. People hurt me, or they pinch me, and nothing happens to me. Or I wear a chappal, a V-slip chappal, and it slips out of my feet. My feet slip out. Or maybe I just looked at my shoes today, and I found out that there was a thorn, or there was a nail embedded in my foot sole, in my shoe sole, and I never realized. And that thorn and that nail had been hurting me. It has created an ulcer in my foot, but I'm not aware of it. So these are the negative symptoms. How do these symptoms occur? They occur directly because of high glucose levels. So this is how we explain to our patients this slide. What glucose does, along with tobacco and cholesterol, it sticks like slime to the inner lining of your blood vessels. These blood vessels then constrict. They are not able to supply the heart, the kidney, the brain, the nerves. Because they are not able to give adequate blood supply to the nerves, that can be because of glucose, tobacco, or cholesterol, the nerves become weak. They are not able to respond. Initially, they respond with pain or with other equivalents of pain, like heat or cold or tingling. But then they also give up and then they go into negative symptoms. They just stop complaining to you. This is one way. The other way of explaining is that glucose sticks like jelly. It sticks to various proteins of the body, and once it sticks, it's not going to come out. That's like, let's say you've got termites in your woodwork. Once the termites are there, then they're not going to come out. So glucose, cholesterol, tobacco. I usually use these three together in my OPD. They stick like termites to all the proteins in the body. These proteins can be anywhere in the body from head to toe. These proteins then get disturbed, just like your woodwork becomes weak. And this weak woodwork or these weak nerves also come in with symptoms. When we are talking about that, we say that sometimes the body tries to respond to these termites, to this high glucose. It responds with reactive oxygen species or with advanced glycation end products. And these also influence in a bad manner. They reduce the efficiency of the nerves in working. While we are on this method of explaining to our patients, we are also taking a history. We are doing an examination and sending for relevant lab tests. Remember that diabetic painful neuropathy is a diagnosis of exclusion. So you have to rule out other causes, which can be nutritional, which can be immune, which can be traumatic. So while you're doing the history taking, ask for positive and negative symptoms both. Ask for history of foot ulcer in the past. Also ask for symptoms suggestive of autonomic neuropathy, which can be cardiac, genitourinary, gastrointestinal, or pseudomotor. Examine the foot carefully for corns and callosities, deformities, also any foot ulcer. See if there are stigmata of autonomic neuropathy, for example, loss of hair over the feet or the distal part of the legs, or perhaps a very shiny, tense skin without sweating, even though the ambient temperature may be uh, high. Do an assessment also. We have to assess for large, small fibers and also for protective sensation. Sorry, advise investigations only when required. But the basic test that we should do, look for anemia, vitamin B12. People have asked about that. Vitamin D. If it is indicated, you do the test. Otherwise, I usually treat empirically. If the patient doesn't respond to empirical treatment, then we must refer to a specialist, and we can do the tests also. But things like hemoglobin, TSH, these tests should be done. This is a questionnaire, an international questionnaire that I was also privileged to be part of while developing it. We have a patient led questionnaire. We can keep these in the OPD, and our patients themselves can fill if they experience any uh, sensations like burning, tingling, electric shock, numbness, pins and needles, or other weird or unusual sensations in the feet or hands. Our patient also feels whether they are bothersome, tells where they experience them, whether these symptoms get worse at night. This is a sign of diabetic neuropathy. And also the other risk factors, metabolic as well as behavioral risk factors that they have. With this, you can start a conversation around neuropathy. The doctor should also complete the questionnaire, and doing a pinprick test or doing a cotton wool or brush test just takes a minute or two. Pinprick and temperature will help us check small fiber function. Vibration sense, the reflexes like knee jerk and ankle jerk, and also 10-gram monofilament will help us check large fiber function. These are usually uh, they go earlier, and protective sensation is checked by 10-gram monofilament test. So if the 10-gram monofilament test is positive, that means patient cannot feel the 10 gram. That means there is LOPS, loss of protective sensation. Restless leg syndrome is a distinct syndrome. This is different from diabetic painful neuropathy. Here, the patient will complain about inability to sleep at night, keeping on moving the legs and arms at night. If the legs are moving, the patient is fine. If the legs lie still, the patient becomes uncomfortable. The best part is, even though the patient is not able to sleep at night, he wakes up okay in the morning. She wakes up okay in the morning, and they do not feel sleepy during the daytime. This diagnosis of restless leg syndrome will be done only by history taking. So, therefore, the key to sort of early detection of neuropathy is clinical. First of all, a good history taking. Secondly, a good physical examination. History taking, let me repeat again, go back to our OPDs tomorrow. So, apologies. And see what are the synonyms associated with pain or discomfort in our languages. How do we manage? We have to control glucose. Along with that, we have to control lipids and blood pressure. This also makes a lot of difference. Specific therapy, we have nutraceuticals available. Earlier, we have used evening primrose oil, various vitamins, vitamin B, vitamin D. We use them because the deficiency is so ubiquitous, so common in the country. We use them to ensure nutritional optimization. Until you optimize the nutrition and the lifestyle, until you optimize the glucose, that is glycemic or metabolic optimization, we will not be able to correct the symptoms of diabetic painful neuropathy. So we control glucose along with that lipids and blood pressure. We ensure good nutrition, which will mean vitamin B, vitamin D, and also alpha lipoic acid. And then we get down to treatment. Now, various treatments are available for pain. In a non-diabetic person with musculoskeletal pain, we would focus on NSAIDs. But in diabetic neuropathy, they don't work too much. ADA 2024 suggests these four classes of drugs as initial therapy. Uh, Gabapentinoids. In India, we have gabapentin and pregabalin. You can use either of them. Gabapentin 300 is equipotent to pregabalin 75. In many patients, the elderly, the frail, those with renal or hepatic dysfunction, I prefer to begin 100 milligram gabapentin, which is equipotent to 25 milligram pregabalin. Uh, Sometimes I use pregabalin 50 milligram to start therapy. So these are the commonest that I have to use for starting. Otherwise, according to the book, the starting therapy is 300 milligram gabapentin or 75 milligram pregabalin. This is what I use most frequently as an initial therapy. Many times, patient has already taken treatment from outside, or patient has severe pain, and the pain is so severe that it is impacting the person's mood or the person's sleep or both. In such cases, gabapentin alone will not act. Then we add either an SNRI or a tricyclic antidepressant. The antidepressants, the SNRIs that we use are duloxetine. That is what I use most frequently. I begin with 20 milligram. So I might give 20 milligram alone if the main issue is mood, or I might want to begin something like uh, pregabalin 50 and duloxetine 20 fixed dose combination at night. I will not begin with anything more than that. I may increase later after 2 weeks or so. If the main issue is sleep, then I will, to the gabapentinoid, that is pregabalin 50, then I will add a tricyclic antidepressant, which can be 10 milligram of amitriptyline or nortriptyline. And again, I will not begin with something heavier than this, though I may increase a week or 2 weeks later. Sodium channel blockers, lamotrigine, carbamazepine, oxcarbamazepine, these are available. I do use oxcarbamazepine in the OPD. This I prefer when the patient has got lancinating pain. And we use it also when patients have got maybe post-herpetic neuralgia. So these are all the initial pharmacological treatments. Let me repeat again. What is approved is use of gabapentinoid, pregabalin or gabapentin. Also, SSRIs, SNRIs. What I use most frequently is duloxetine 20 milligram, tricyclic antidepressants, amitriptyline, nortriptyline 10 milligram. To begin with, you can go up till 25 or 75. And sodium channel blockers like oxcarbamazepine 300 milligram BD. That's the average starting dose. You can always reduce or increase. Begin with single therapy. If required, add a second therapy after a couple of weeks. Now, the American Academy of Neurology gives relatively higher starting dose, but in India, our patients don't tolerate, so stick to lower dose. But AN does say that the initial treatment of pain should also focus on the concurrent treatment of sleep disorders and mood disorders. So, therefore, when you're talking about neuropathy, do ask your patient, do these symptoms impact your sleep? Do they impact your mood? Do you remain happy? Are you happy in the morning? Are you happy at night time? And if sleep is an issue, add non-benzodiazepine sleep-inducing drug, or you might want to add amitriptyline. If mood is an issue, add maybe duloxetine or amitriptyline, whatever you feel like, but you can add that initially. Depending upon what the patient says to you, you can choose your initial drug of choice. So, lancinating pain, maybe carbamazepine, pain with depression, duloxetine, fluoxetine, causalgia, carbamazepine or pregabalin would be a good idea. For gnawing pain, opioids. So, otherwise, opioids will be second or third line. Do not use it immediately. You can use tapentadol or tramadol, but these have addictive potential, so avoid using them. One other drug that I use, it is a centrally acting non-opioid. This is Nifopam, NEFOPAM, 30 milligram BD, 30 milligram TDS, and you can use it for a short period of time. Burning pain, we can use localized capsaicin ointment or patch as well, and lidocaine patch can be used. So we've talked about painful neuropathy today. We've talked about the need to focus on history as well as examination, and then to treat properly. Whatever treatment we do, it continues for quite a few weeks or months. So you tell the patient, let's stabilize your nerves. And patient says, when can I go off these tablets? As soon as you are able to control and maintain your glucose, lipids, and blood pressure, we will begin reducing the dose, but we will not stop suddenly. We will reduce slowly. With this, let's remind ourselves of the primary goal of managing painful neuropathy in individuals with diabetes. So this is quiz question one. What is our primary goal? Is it to alleviate symptoms of painful neuropathy, to minimize fluctuations in glucose level, to manage mood and sleep disorders if they are there, or all of the above? So, do we want to improve the patient's symptoms, minimize fluctuations in glucose, and manage mood and sleep disorders, or all of the above? Second question is, which strategy is effective in managing painful neuropathy? A. Begin with pregabalin or duloxetine. B. Add a second drug if there is no relief in a few weeks. C. Nutritional optimization using micronutrients like vitamins and alpha lipoic acid. And D. All of the above. So, question two, which strategy is effective in managing painful neuropathy? A. Begin with pregabalin or duloxetine. B. Add a second drug in a few weeks if required. C. Nutritional and micronutritional optimization. And D. All of the above. With this, let's come to our questions today. And I'd like to thank everyone for having logged in. Thank you for all the answers from everyone. So, Dr. Devraj says in neuropathy, vitamin B1, B12. Yes, many of our patients are vegetarian and vegan, and all the vitamins will be required. B12 is more important. B1 is required more for brain function, but both should be given. Anup Shuklaji says that for the last 30 years, he has sugar, BP, and uh, and retinopathy and neuropathy as well. And he's on insulin. The HbA1c is not coming below 7, even though he cycles for 15 kilometers every day. So that's very good. Just continue the cycling, and maybe the insulin regimen needs to change. If the HbA1c is not coming down, that means we should change the insulin. If you are on twice a day insulin, ask the doctor to put you on 3 or 4 injections per day for around 6 weeks, and you will find the HbA1c coming down. Secondly, we should do the kidney test before we suggest any medicine, because some of the medicines may not be helpful if the kidney is not working properly. Dr. Devraj says, yes, many people have burning pain, many people have numbness without diabetes. Here, the treatment is nutritional optimization, lifestyle optimization, and vitamin B can be given. The same medicines will be used for burning pain. Like we said, pregabalin or gabapentin, uh, tricyclic antidepressants, and also the SSRIs. Dr. Pradeep and Dr. Aditya, greetings. Same to Mr. Sharma as well. And warm welcome, Dr. Armias from Ethiopia. It is very good to have you with us. So thank you, Dr. Gabriel Mikhail, for being with us today. Gamma linoleic acid, Dr. Arnias asks, and I actually use it a lot in my practice. I used to use it more frequently, I think, earlier because less drugs are available, but it is effective in both painful neuropathy and also in uh, neuropathy with negative symptoms like numbness. Another drug you can try is alpha lipoic acid. In India, we call it alpha lipoic acid. In Egypt, Ethiopia, I think it is known as thioctic acid. THIOCTIC, thioctic acid. This will also be helpful. But the gamma linoleic acid and thioctic acid or alpha lipoic acid, they will sort of try to stabilize the nerve membranes. For the pain, we will have to add a medicine. First line, pregabalin or gabapentin. Second line, amitriptyline or duloxetine, fluoxetine. Third line, opioids like tapentadol, tramadol. Dr. Mukesh asked about levocarnitine and coenzyme Q. These are used more in muscular cramps than in peripheral neuropathy. So they will not help us directly in peripheral neuropathy. But if your patient has muscle weakness, they may help. This is empirical therapy. Now, when patient comes to you with pain, there is something known as MOAN syndrome, MOAN. Patient is coming and saying pain or weakness. Patient is not telling you whether he has got M for muscle, O for osteo, that is bone, A for arthro, and N for nerve disease. So if when you take a history, you feel it is more of muscle cramps, muscle weakness, then you can consider giving levocarnitine or coenzyme Q. Do rule out myositis, which can occur after statin therapy, which can also occur after uh, many viral fevers like chikungunya. Even there is, we speak of drug drug interactions, drug food interactions, but there are also drug sports interactions. And Dr. Armias comes from a country which has got so many Olympic medalists in the marathon. So if you are doing a normal uh, exercise regimen and you're taking statins, then there will be no issue. But if on statins, suddenly you increase the intensity of exercise, suddenly from 30 minutes workout every day, you begin going to 10 hours workout every day, then that can precipitate myositis. So our sports persons and sports physicians should be aware of this. Similarly, you are exercising and suddenly one fine day from 10 milligram, you jump to 40 milligram atorvastatin, even though the exercise is the same. That can also precipitate myositis. The treatment, just stop the statins for 4 weeks, check CPK. If it is okay, you start all over again. And also counsel the patient not to go overboard for exercise. Dr. Shashi Khare points out that semaglutide, levothyroxine both have to be taken fasting. So, two options for taking them. Either you take the semaglutide earlier, maybe at 6 a.m. with half a glass of water. 30 minutes later, we take levothyroxine, and 30 minutes after that, we take breakfast. So, this will be 1 hour gap. Uh, or you can shift levothyroxine at night. So, how we will counsel the patient? Either you take the tablet first thing on waking up in the morning, or you take it last thing while going to bed before switching off the light. Both are okay. Whenever you start semaglutide in a patient on levothyroxine, or Vice versa, start thyroxine in a patient on semaglutide, then it's a good idea to check TSH after 45 days, not after 90 days. And you may be able to reduce the dose of thyroxine by 12.5 microgram or so when the patient is on sema. Why will this occur? Number one, semaglutide will reduce body weight. So, levothyroxine dose is based on body weight. Second, semaglutide may increase the absorption of thyroxine. Increase, not reduce. Increase the absorption of thyroxine, so the efficacy will go up. Dr. Mukesh asked about canagliflozin. The answer is, Dr. Mukesh, that it is more expensive than DAPA and EMPA. Dapagliflozin, empagliflozin are so economical, that is why they are used more frequently in the country. And Cana continues to be at the old expensive rate. Dr. Gauri Shankar from Karnataka, warm greetings, sir. He shares case of a patient with gastritis due to vildagliptin and metformin. We can reduce the dose of metformin for some days. We can give 250 milligram BD, or we can add proton pump inhibitor. If proton pump inhibitor doesn't work, a good drug to add is rebamipide. Rebamipide, 100 milligram BD for 10 days or so. Ask the patient to increase hydration as well and to take more of curd. So I don't know the Kannada for this, but I know the Telugu. Ek pav perugu. That is 250 grams of curd. So you tell the patient to take 150 grams of curd 2-3 times a day, and the gastritis will resolve. Patient can also eat little bit of curd rice 3 times a day, maybe 100 grams total, and that will also reduce the gastritis. But in drugs, like I said, apart from PPI, we can give ribamapide for some time. In Dr. Shuklaji's case, where for neuropathy, gabalin 150 is being given, and still the issue is okay, is not controlled, we can give gabapentin up till 300 milligram very safely. So we can increase the dose. If sleep is an issue, then we should be able to add a sleep inducing drug that will also help you. Chronic constipation in people with diabetes is really tough to handle. So some of the folk therapies we tell are to drink hot milk at night or to drink water with baking soda. That helps them. Also look at the drugs. Virtually all the glucose lowering drugs, metformin as well as SGLT2 inhibitor, they can cause constipation. So try to reduce as many drugs as possible. Maybe patient is on iron, calcium, multivitamin. Try to stop these for some time. Uh, when this doesn't work, one of the drugs that we use is Provect, 1 milligram or 2 milligram at night, which increases the gut motility. You can give for a few weeks. And Dr. Aditya points out rightfully so that because levothyroxine is influenced by oral semaglutide, we can give subcutaneous semaglutide in these patients. Subcutaneous is available abroad, not available in India as of now. But when it comes, it is a weekly injection. Certainly, it will be prepared. Thanks, Dr. Aditya. Dr. Gauri Shankar, good book for diabetes. There are multiple. My favorite is actually from CMC Vellore. This is edited by Professor Nihal Thomas and Professor Nitin Kapoor. And we'll try to get Dr. Nitin Kapoor on our show sometime in the next few weeks. So it is, I think, called a practical manual of diabetes. And the editors are Nihal Thomas and Nitin Kapoor, Professor Nihal and Professor Nitin. This is my favorite book from CMC Vellore. Uh, so when diabetes is uncontrolled and nerve weakness is there, there can be multiple causes. Then we have to investigate. And if things are not coming out right, Nitin, then we need to go to a neurologist. We'll do more tests. Aditya points out that canagliflozin causes Raynaud phenomenon and thrombotic, so also not preferred. That's true. And earlier there was this issue about increased risk of amputation with canagliflozin, though later on studies found that this was not true. Dr. Aditya shares his experience. RSSDI books and diabetic update books are also very good. Thanks. For intertrigo, local therapy will be better. Fluconazole or luliconazole ointment. And sometimes, if it doesn't work, you have to give both oral and local therapy. And in intertrigo, you have to give for a longer period of time, maybe 10 to 14 days. The drug can be fluconazole, itraconazole. Both of these increase the efficiency of sulfonylureas through drug-drug interactions. And you can also give terbinafine. Thank you, Ditya and Aline Zakaji, for your kind words. How to taper off, Manu, based upon the symptoms. So we speak with the patient. When the patient says, I'm comfortable, you reduce the dose to roughly half and then wait for a month. Usually, in my experience, not 100, but 80% of patients stop on their own because they are comfortable. The other 20 keep on taking for a long period of time. Good evening to Dr. Siddharth Dhanger from Mathura as well. A warm welcome. Dr. Bharat Praveen asked about apelristat. This is a good drug provided you give it early on in the course of events. I did use about maybe 15 years ago, but the results were not very good in my clinic. The reason is that patients present very late. If a patient comes with severe pain or with symptoms, then we have missed the bus for ipalristat. If, however, you pick up neuropathy in a patient who is asymptomatic, you pick it up on signs, then the drug will actually help in the long run. But then the issue is the patient doesn't have the feeling. Unless you do a biothesiometry and you show him a number, then you may be able to motivate the patient to take a palristat. Otherwise, patient will say, "Sir, I am asymptomatic. Why should I bother?" So in such a situation, the best you can do is see your numbers are not very good. Your 10-gram filament, your biothiometry is not good. So at least take care of your blood pressure, your glucose, and your lipids. So that we can do. And diffuse cellulitis is very difficult. So if piperacillin sensitive and costly, we have to give that for some period of time. We have to trust and respect uh, the pus culture report. Also, make sure this patient is on insulin. Otherwise, later on, we may get in trouble. So, even if glucose is relatively normal, still put the patient on insulin until the cellulitis uh, sort of is managed. If we cannot afford piperacillin, then my go-to antibiotic in cellulitis is usually coamoxiclav, and that is quite economical now. We have good brands, so you can use coamoxiclav maybe in a normal weight patient 625 TDS, in a lighter weight patient 625 BD. Nadeem Sahab's dad has diabetes, but we wish him all the best, and we hope that he remains fine. Glycoside is and glimepiride, both are good. Both are modern sulfonylureas, Nitin. In terms of hypo, both are fine, but head-to-head glycoside. Sorry, if I were to choose, maybe glycoside would be better. Actually, glycoside is very safe to use in Ramzan also, in the holy month of Ramzan. So it doesn't cause hypo even during Ramzan. Fruity smell comes from urine. That is a smell of ketones. It is because of glucose. Glucose gets converted to ketones. So the smell of ketones is fruity odor, sick fruity odor. And Nadeem Saab, blood in his urine, pus was normal. Metformin, glimepiride, sitagliptinol will be safe. Uh, Maybe we need to treat a UTI even though the pus cell count was normal, and then repeat again after 10 days. I think that will help. If it doesn't help, a urine an ultrasound of the abdomen, even if that doesn't give you the reason, then we have to get a cystoscopy done. They will do a cystoscopy to find out where the blood is coming from. Having said all this, there is something known as asymptomatic hematuria. Asymptomatic means Nadeem Sahab has no issue, but there is hematuria, there is blood in the urine. This is innocuous, you don't need to worry, provided that all the tests have been done and they are normal. If the tests are done and they are normal, then just don't worry, that's part of life. But treating for UTI first is correct. The next step would be to do repeat a urine routine. And if there is still hematuria, then an ultrasound abdomen for prostate, followed by, if required, a cystoscopy. Good evening to Vinayak Sharma ji. And okay, Dr. Shashi Khare says that patient has DAPA, CETA, and metformin, but fasting is not coming down. I think we should stop the sitagliptin and shift to glimepiride or glyclazide. So keep the patient on three drugs only, unless you are saying four drugs. Glycivate G, no, it's three drugs only: DAPA, CETA, and metformin. So I would suggest that we stop sitagliptin and stop sitagliptin and add either glimepiride 2 milligram BD or glyclazide XR 60 milligram BD. See what happens. You will be pleasantly surprised. The daytime glucose will actually come down, and you will have to reduce the morning dose of glimepiride to 1 milligram or glyclazide 60 to 30 milligram within a week, and then see how things go. So do this first, and then let's see what happens. So Coam Oxyclav is what I use first of all, along with the metronidazole. Thanks to Dr. Ranjit Pratap from Chrompet for this question. Thank you, Aditya. And we look, I feel very happy, when I see our young boys and girls working so hard. And I really feel that our country, our diabetes care in our country is in safe hands. So it makes me very happy and very contented, actually. Contentment is the right word for what I feel. When to shift insulin to OAD, this is assuming we are talking about painful neuropathy or foot infection. So, one of the morbidities that occurs with neuropathy is foot infection and foot ulcer. It can go up to amputation if we don't take care. Tell the patient, let the foot become okay. Whatever issues that were there, foot infection, cellulitis, kidney disease, hepatic impairment, let it become okay. Wait for 2 to 4 weeks. After that, we will reduce the insulin slowly. Do not stop suddenly, it will go down slowly. Dr. Lambe, thank you, sir, for your kind words. Diabetes is ITP platelet 30,000. If the patient is on steroids, which probably they will put on steroids, then it would be a good idea to be very glucovigilant. Keep on checking glucose. Whatever medicine the patient is taking, let him continue that. Increase the dose by 1.5 times. But if patient is on prednisolone, methylprednisolone, the highest glucose you will see post lunch or pre dinner. So you will have to add something at lunchtime. That can be a small tablet of acarbose or voglipose. It can be short-acting metformin. It can be a short-acting sulfonylurea like glipizide, or maybe meglitinide like repaglinide. Any of these. What I use most frequently would be acarbose and glipizide, followed by repaglinide. Glipizide is the most economical of all these. If still glucose is not controlled, then we need to give insulin. But usually premixed will not work in these patients. You have to give something at lunchtime. So either we give rapid acting at breakfast, rapid acting at lunch, and premixed at dinner, or we give a proper basal bolus. Tell the patient that as steroid therapy is titrated downwards, insulin therapy will also be titrated downwards so that patient is aware. Thank you, Manu, for being with us. Thanks, Rahul Desai, for being with us. And it's great to be with you. The best book, Dr. Gauri Shankar asked, the best book for me is being with all of you, and I keep on learning so many things. Ankur, what do you think? What does FDC Diabetes Essentials do to your hormones and your health?
So all well, sir, all well.
Right. So
Yes,
it's
sir.
great.
So thank you, Sanjay sir, for to speak on the topic, and we are very grateful for your knowledge and experience which you share with all of us. And it's a very pleasure to have you with us, sir. And I would like to thank all the doctors to take part every week in our quiz and to attend and to give your time and attention. So thank you, everyone. And we will once again we will meet next week again. So thank you so much. Jai Hind.
Jai Hind.